Hey guys, welcome to lecture 7 of our cardiovascular series for USMLE Step 1. Today we're going to dive into mitral valve disease, covering both mitral regurgitation and mitral stenosis. Let's get into it. Let's start with the basics of mitral regurgitation or MR. Mitral regurgitation means that blood flows backward from the left ventricle into the left atrium during systole, when the heart is supposed to be pushing blood forward into the aorta, right? Now this can happen for two main reasons. Number one, if there is a structural defect in the mitral valve itself, that's what we call primary MR. Number two, if the left ventricle is dilated or dysfunctional and the valve is pulled apart even though the valve itself is normal, and that's secondary MR. In chronic MR, the left atrium and left ventricle have time to adapt. They undergo eccentric hypertrophy, meaning both chambers dilate to handle the increased volume, right? This compensation maintains forward output for a while, but eventually it's going to lead to volume overload and heart failure if left untreated. In acute MR, there is no time to adapt. The sudden backflow of blood raises pressure in the left atrium and pulmonary circulation very quickly. That's going to lead to pulmonary edema, hypotension, and possibly cardiogenic shock. And this, of course, is a medical emergency. So a quick recap for you guys. MR, backflow from left ventricle to left atrium during systole. Primary MR, valve problem. Secondary MR, LV problem. Chronic MR, dilation and compensation. Acute MR, pressure overload, pulmonary edema, and shock. Let's bring this back to the pressure volume loop and think about what's happening inside the left ventricle in mitral regurgitation. Remember, this loop shows the relationship between pressure and volume throughout the cardiac cycle. Now, in MR, the end diastolic volume is increased. Why is it increased? Because the ventricle isn't just receiving blood from the lungs, it's also getting regurgitated blood that leaked back into the left atrium during the last systole. So we're dealing with volume overload, and that's reflected by the loop shifting to the right. It might look like the stroke volume is increased, right? Because the total volume ejected is bigger, but that's misleading. Only part of that volume is actually going forward into the aorta. The rest is just leaking back into the left atrium again, so the effective forward stroke volume is reduced. The effective forward stroke volume is reduced, even though the loop appears wider. And here's another key point. There are no true isovolumetric phases in mitral regurgitation. Why? Because the mitral valve never fully seals. During isovolumetric contraction, blood leaks backward into the left atrium. During isovolumetric relaxation, the valve is already open or still leaking, so there is no phase where volume stays constant and the loop loses its vertical sides. Now let's look at the pressure time curve. We're looking at the changes in pressure over time in the aorta, left ventricle, and left atrium, all during a single heartbeat across one RR interval. You got that, right? And here's the big clue for mitral regurgitation. You see an abnormal rise in left atrial pressure during systole. This bump that's not supposed to be there. Let's think about it. During systole, the left ventricle should be contracting and ejecting blood forward into the aorta. The mitral valve should be closed, so no blood should be going into the left atrium. But the valve is incompetent, and some of blood leaks backward into the atrium. That regurgitant flow raises left atrial pressure during systole, and you can clearly see that pressure bump on the curve. This finding, a rise in left atrial pressure during systole, of course it's not normal, and it's one of the classic hemodynamic signs of MR. In a normal heart, the left atrial pressure should be stable or even falling slightly during systole, since it's just passively, receiving blood from the pulmonary veins. But in MR, that pressure spikes, and that's your clue. Let's proceed. Now let's go over the etiologies of mitral regurgitation. And we're going to split them into chronic primary, chronic secondary, and acute causes, okay? Because they have different mechanisms and clinical implications. In chronic primary MR, the problem lies in the valve itself. You know that something is wrong with the mitral apparatus. The most common cause is mitral valve prolapse, often due to myxomatous degeneration. Very hard for your test. So remember that. The most common cause of chronic primary MR is mitral valve prolapse, often due to myxomatous degeneration. That's where the valve leaflets become floppy and redundant. Okay? Other causes of chronic primary MR are 1. Rheumatic heart disease, especially in patients from lower resource settings. 2. Infective endocarditis, which can damage the valve over time. And 3. Congenital defects, like endocardial cushion defects, which are commonly seen in Down syndrome, for example. Now, in chronic secondary MR, the valve is actually structurally normal, but the ventricle is the problem. When the left ventricle dilates, like in ischemic heart disease or dilated cardiomyopathy, it pulls the papillary muscles apart and stretches the mitral valve annulus. The result? The valve leaflets can't co-opt properly, and you get regurgitation, even though the valve itself is intact. This is often referred to as functional MR as well, and it's a common finding in advanced heart failure. Okay, all right? In acute MR, we have a different story. It comes on suddenly, and the heart has no time to adapt. The classic causes include papillary muscle rupture, very high yield for your test, usually after the MI, chordae tendineal rupture, often in patients with mitral valve prolapse. This chordae tendineal rupture can come from papillary muscle rupture, which in turn comes from an MI, but we might have chordae tendineal rupture out of the context of an MI in a patient with mitral valve prolapse. Did you know that? Infective endocarditis, especially from staph aureus, which can destroy the valve rapidly. An iatrogenic injury, for example, during a cardiac surgery or catheter-based procedures. These patients often present with shock, pulmonary edema, hypotension, and it's a surgical emergency. To summarize for you, chronic primary MR, valve abnormality, mitral valve prolapse, rheumatic heart disease, endocarditis. Chronic secondary MR, ventricular dilation pulling the valve apart. Acute MR, sudden structural damage, papillary muscle or chordal rupture, or endocarditis. All right, let's go. Clinical features of mitral regurgitation, and as usual, we separate into chronic and acute because the presentation is very different depending on how fast the regurgitation develops. In chronic MR, there is usually a long asymptomatic phase. The left atrium and left ventricle slowly adapt, they dilate, they stretch, and the patient can feel fine for years. But eventually, symptoms appear, usually related to left-sided volume overload, like exertional dyspnea, orthopnea, paroxysmal nocturnal dyspnea, and fatigue from reduced forward output. Now here's a key turning point. When the left atrium dilates, the patient is at risk of developing atrial fibrillation. And once AFib sets in, symptoms can worsen suddenly in this kind of patients. Because now you've lost the atrial kick, right? And feeling becomes even more compromised. So if a patient with MR suddenly decompensates, think about the onset of atrial fibrillation. Interesting, right? In acute mitral regurgitation, there is no time to adapt. There's no time for the heart to compensate. The left ventricle is suddenly overwhelmed by a huge volume returning from the left ventricle to the left atrium, and pressure rise fast. This is going to lead to flash pulmonary edema, severe hypotension, and cardiogenic shock. Physical exam findings in mitral regurgitation, and there are several that Step 1 loves to test. Murmur first. The hallmark is a holosystolic murmur. That means it lasts throughout systole, holosystolic. And you hear it best at the apex, and it radiates to the axilla, okay? In patients with mitral valve prolapse, the murmur sound is a little different. you're gonna hear a mid-systolic click followed by a late systolic murmur. Mid-systolic click followed by a late systolic murmuring. Patient with mitral valve prolapse. The click comes from the sudden tensing of the prolapsing valve leaflet. Okay? And it's often heard in young women. In terms of heart sounds, the S1 is often soft in patients with MR. Why is it? Because the mitral valve is already partially open or floppy, so the closure sound isn't as sharp. You may also hear an S3 to thra, especially in chronic MR due to volume overload and rapid filling of a dilated ventricle. On palpation, you often find a laterally displaced point of maximal impulse. And that's your clue for eccentric hypertrophy in your test, okay? The ventricle dilates in response to the chronic volume overload and shifts the impulse outward and downward. Let's just remember how we can increase the intensity of this holosystolic murmur. We can increase it by increasing preload or by increasing afterload. We can increase preload, for example, doing leg raise, and that's why you increase the holosystolic murmur. Or you can increase afterload, and because the resistance of blood flowing across the aorta is increased, for example, doing hand grip, more blood will go back into the left atrium, and we're going to increase the holosystolic murmur, the intensity of the holosystolic murmur as well. Okay? All right. To diagnose mitral regurgitation, no mystery here, echocardiography. Transthoracic echo, this is the first line imaging test. On echo, we're going to see regurgitant jet of blood flowing from the left ventricle back into the left atrium during systole. No mystery as well. That's your key visual finding. And if the regurgitant volume is 50% or greater, that qualifies as severe mitral regurgitation. You also likely see left atrium, left ventricular dilation. You can see that, especially in chronic cases after a while. Both chambers adapt over time to the increased volume. And here's an important detail. The ejection fraction may appear preserved early on, right? But don't let that fool you. You already learned that. The forward cardiac output is actually reduced, and the EF only drops later when the ventricle starts to fail. On ECG, you may see signs of left atrial enlargement, like a wide notched P wave in lead 2, D2, or a biphasic P wave in V1. And if the left atrium is stretched enough, the patient may develop atrial fibrillation, another high-yield clue for you. Okay? On chest X-ray, you typically see left atrial and left ventricular enlargement. In more advanced cases or acute decompensation, you might also see signs of pulmonary edema like vascular congestion or curly B lines. Non-specific findings. Differential diagnosis. In mitral stenosis, you're going to hear a diastolic murmur, not systolic. Aortic can also cause volume overload, and it can have a bounding pulse and widened pulse pressure just like MR. But the murmuring AR is diastolic, not systolic. All right? Now for tricuspid regurgitation, this is a right side murmur. It's also holosystolic, but it's going to get louder with inspiration. It's best heard at the left lower sternal border and gets louder with inspiration, which is Carvalho's sign. You know that. Finally, don't forget about high output states like anemia, pregnancy, or thyrotoxicosis. These patients may have bounding pulses, wide pulse pressure, hyperdynamic circulation, but here's the difference. There's no murmur, or there is just a functional systolic murmur, okay? And the valves are structurally normal. All right, let's go. Management of chronic primary mitral regurgitation. Chronic primary mitral regurgitation. This is when the problem is in the valve itself, not secondary to LV dysfunction or anything like that. The definitive treatment is mitral valve surgery, okay? A valve repair is preferred over replacement whenever possible because the repair preserves native anatomy and has better long-term outcomes. That makes sense, right? If the patient has severe MR, severe mitral regurgitation, but no symptoms, we monitor with echocardiography every 6 to 12 months. Watching for any signs of decompensation or ventricular changes. Surgery is indicated if any of the following are present: symptoms of heart failure, you're going to indicate surgery, or ejection fraction between 30 and 60%, or LV and diastolic dimension greater than 40 millimeters. Even in some patients with EF above 6%, surgery may be done preemptively, especially if the valve is likely to be repairable and the patient is a good surgical candidate. Okay? So it's going to be assessed case by case. But usually, symptoms of heart failure or EF between 30 and 60%, or LV and diastolic or end systolic dimension greater than 40 millimeters. Okay? All right. Medical therapy. Medical therapy doesn't fix the valve, but it can help manage symptoms or bridge patient to surgery, right? Gonna use diuretics for volume overload, vasodilators like ACE inhibitors or dihydropyridine calcium channel blockers can reduce regurgitant volume by lowering afterload. So I'm gonna facilitate the blood to go forward into the aorta, and less blood will go backward into the left atrium. If the patient has reduced ejection fraction, I'm gonna initiate GDMT, goal-directed therapy for HFrEF, including beta blockers and ACE inhibitors. Did you get that? All right. Acute mitral regurgitation. This is a surgical emergency. There's no time for compensation, and the sudden increase in volume causes rapid pressure, build-up, pulmonary edema, and potentially cardiac shock. You already know that. The definitive treatment is urgent, emergent surgery, usually mitral valve replacement. In the meantime, you can stabilize the patient with vasodilators to reduce afterload, and in some cases, an intra-aortic balloon pump, okay, to improve forward flow and reduce regurgitant flow. This can bridge the patient to the operating room. But again, the priority here is rapid surgical intervention. In secondary MR, the valve itself is structurally normal. The problem is the left ventricle. So the primary goal is to treat the underlying cardiomyopathy using goal-directed medical therapy, GDMT for HFrEF, ACE inhibitors, beta blockers, mineralocorticoid receptor antagonists, and possibly ARNI or SGLT2 inhibitors. Okay? If the patient still has persistent symptoms despite optimal therapy, then interventional options like a mitral clip, percutaneous, edge-to-edge repair, you remember that, can be considered, especially in high-risk surgical patients. Okay? All right, complications. In chronic MR, the key long-term issue is heart failure with reduced ejection fraction. Why? Because over time, the chronic volume overload causes the ventricle to dilate and eventually loses contractile strength. Okay, straightforward. Another important complication and very high for your test is atrial fibrillation. As the left atrium enlarges from volume overload, it becomes more, irritable. And once AFib sets in, you lose the atrial kick, and the patient may decompensate, and you face a higher risk of thromboembolism, including stroke, okay? We can also see pulmonary hypertension as the elevated pressures are transmitted backward into the pulmonary circulation, and eventually this can cause right-sided heart failure, all right? Now, in acute MR, the situation is more dramatic. There's no time to compensate, you know that, and the patient can go into cardiac shock or even die if left untreated. It's a surgical emergency. In terms of prognosis, in chronic MR, we have an excellent prognosis if the valve is repaired or replaced at the right time, okay? The key is to intervene before the ventricle begins to fail. It makes sense, right? And here's something to remember. Repair is generally better than replacement. It preserves valve function, has fewer complications, and leads to better outcomes long term. Okay? Sounds good? All right, so now let's move into mitral stenosis, or MS. Step 1 loves to test it. Mitral stenosis means the mitral valve doesn't open properly during diastole. So blood flow from the left atrium to the left ventricle is restricted. Okay? The most common cause by far is rheumatic heart disease. Even if the patient had rheumatic fever years earlier, the scarring and fibrosis can gradually cause the mitral leaflets to thicken, calcify, and fuse, leading to stenosis over time. So what happens next? The obstruction causes pressure to build up in the left atrium. Blood can't flow, freely into the left atrium ventricle. This leads to left atrial dilation, which can trigger AFib as well. And that pressure gets transmitted backward into the pulmonary circulation as well, like MR. Over time, you develop pulmonary hypertension, and eventually that can lead to right-sided heart failure, exactly the same step-by-step that will, end up happening in the long-term and untreated MR. So to summarize the core pathophysiology of mitral stenosis, we have impaired mitral valve opening, we have restricted LV filling during diastole, we have increased LA pressure leading to pulmonary hypertension and eventually to right ventricular failure. Okay? Pressure volume loop in mitral stenosis, once more, and this one is really straightforward once you think it through. In mitral stenosis, the problem is underfilling. The left ventricle isn't receiving enough blood because the mitral valve is stenotic, and everything happening here in this loop is within the left ventricle. So what happens on the loop? The end diastolic volume is reduced. The ventricle just doesn't fill up the way it normally would, right? And according to the Frank-Starling principle, if there is less preload, you're going to get less stroke volume. The ventricle simply doesn't have enough blood, enough volume to generate a strong contraction. So what you see on the loop is a narrower shape, shifted a bit to the left, reflecting lower filling volume and a reduced stroke volume. Okay? Sounds good? Pretty easy to recognize mitral stenosis on the pressure time curve once you know what to look for. In a normal heart, during diastole, the left atrial pressure and left ventricular pressure should be almost the same. They track closely because blood flows freely from the atrium into the ventricle. But in mitral stenosis, that flow is restricted, and what you see on the curve is that the left atrial pressure stays elevated throughout diastole. Left atrial pressure stays elevated throughout diastole. The LA pressure doesn't come down to meet the LV pressure like it's supposed to, okay? All right. Let's take a moment to talk about the underlying pathology and how the valve actually changes in mitral stenosis. It all starts with chronic inflammation. You know that in most cases, that inflammation is due to rheumatic heart disease. Over time, that chronic inflammation leads to 1. Fibrosis, 2. Thickening of the valve leaflets, and 3, and most importantly, fusion of the commissures. The edges where the valve leaflets meet, that's commissures. And this commissural fusion is actually the hallmark of rheumatic mitral stenosis. Okay, so get that. As the disease progresses, you also get calcifications of the mitral valve leaflets, which stiffens the valve even more and further limits its ability to open during diastole. So structurally, the valve becomes thickened, immobile, and narrowed, okay? With a funnel-like opening, sometimes described as fish mouth appearance on pathology, okay? Etiologies of mitral stenosis, the most important cause and the most common worldwide, you already know, rheumatic heart disease. It results from rheumatic fever, usually in childhood or adolescence, and it's going to lead to progressive inflammation, scarring, and commissural fusion. We discussed that, and, mitral valve fusion and calcification over time. This, is the classic cause you're going to see in step 1 vignette, to be honest, especially in patients from low resource settings or countries where rheumatic fever is still prevalent. Okay, keep that in mind. Another less common but important cause is radiation to the chest. For example, in a patient treated for Hodgkin lymphoma or breast cancer. It's not going to happen right away, right? So it's going to take about 10 to 20 years after radiation exposure for valve damage to appear. And in older adults, usually over age 65, you may see calcifications of the mitral annulus. This is often an incidental finding on imaging and usually mild, but in some cases it can progress to a true stenosis. Okay? All right. Clinical presentation of mitral stenosis. And just like aortic stenosis and regurgitation, the symptoms usually appear late, after a long asymptomatic phase. Okay? So many patients stay asymptomatic for years, even though the valve is gradually narrowing and narrowing. All right? When symptoms do show up, they typically reflect pulmonary edema, pulmonary congestion, and low cardiac output, like dyspnea on exertion, the most common first complaint, fatigue from reduced forward flow, orthopnea, and paroxysmal nocturnal dyspnea, as pressure backs up into the lungs. And here's a classic but high-yield symptom, hemoptysis. Think about that, hemoptysis. Why? Because the pulmonary venous hypertension. When the pressure gets high enough, it can cause capillary rupture and bleeding into the airways. All right? Atrial fibrillation, another common feature, but sometimes the first symptom is atrial fibrillation. Remember, the left atrium is under pressure, it starts to dilate, that makes it irritable and more prone to AFib. And once AFib sets in, it can lead to sudden symptom worsening or even a stroke because of left atrial thrombus formation from stagnant blood flow. Okay? As the pulmonary pressure increases, that eventually strain the right heart. You know that, leading to jugular venous distension, peripheral edema, and ascites. This is when mitral stenosis start looking like right-sided heart failure, even though the primary problem is on the left side. One more important clinical setting, pregnancy. The increased blood volume in pregnancy can unmask previously silent mitral stenosis. Learn that. So a woman who felt fine before may suddenly present with dyspnea, fatigue, or pulmonary edema because she got pregnant. Okay? Hoarseness, classically known as Ortner's syndrome. What's happening here? The left atrium becomes so enlarged, it starts to compress the left recurrent laryngeal nerve. Remember which nerve is this? That's a branch of the vagus nerve that loops around the aortic arch. Okay? So this nerve innervates the vocal cords, and when it gets stretched or compressed, the patient develops hoarseness of voice. Make sense? Dysphagia, same idea here. The enlarged left atrium presses on the esophagus, which lies just posterior to the heart. So in late-stage mitral stenosis, patient may report trouble swallowing, especially solids. Physical exam findings in mitral stenosis, really high yield for step 1. The hallmark finding is an opening snap followed by a low-pitched diastolic rumble, best heard at the apex, especially in the left lateral decubitus position, right? So you're gonna hear an S2, then a sharp opening snap, and that's the mitral valve trying to open under pressure, and then the diastolic rumble as blood flows through the narrowed valve. In patients with normal sinus rhythm, the murmur gets louder right before S1. That's called the pre-systolic accentuation. It's due to atrial contraction, given that, final push of blood through the stenotic valve. But if the patient develops atrial fibrillation, that accentuation is lost because you no longer have a coordinated atrial kick. Other heart sounds that you might hear in patients with mitral stenosis are, for example, a soft S1 for obvious reason. The thickened immobile valve doesn't close sharply, so S1 will be soft. P2 may be loud, for example, if the patient has developed pulmonary hypertension already. You might also hear a right-sided S3 or S4, especially if there is right ventricular strain or failure, for example. The point of maximal impulse will be normal in mitral stenosis, okay? There's no left ventricle, volume overload or dilation or anything like that. Left ventricle is normal, just not, receiving enough blood. And here is a great step 1 detail. The shorter the interval between S2 and the opening snap, the more severe the mitral stenosis. Okay? Why? Because when left atrial pressure is very high, it forces the valve open earlier in diastole. That's a direct clue that the gradient between left atrium and left ventricle is large, which means tight valve. So I'm going to repeat, the shorter the interval between S2 and the opening snap, the more severe the mitral stenosis. All right, diagnostic workup for mitral stenosis. On ECG, you often see signs of left atrial enlargement, like broad and notched P wave in lead D2, for example. That's classic P mitrale. You already know that. or a biphasic P wave in lead V1, Morris index. If the disease has progressed, you may also see right ventricular hypertrophy, since the pressure eventually backs up into the pulmonary circulation and right heart. And don't forget atrial fibrillation. It's a common rhythm disturbance in patients with MS, especially as the left atrium dilates. On chest x-ray, you likely see signs of left atrial enlargement, non-specific findings, which can actually displace and elevate the left mainstem bronchus, visible especially in lateral films. You might also see, signs of pulmonary edema if the patient is decompensating, findings like curly B lines or vascular redistribution, okay? Echo is the key test, right? It's going to confirm the diagnosis and determine severity. We're going to look for one, increased transmitral pressure gradient during diastole. During diastole, remember, the mitral valve should be open and the blood should be flowing freely in between left atrium and left ventricle. So if you have a transmitral pressure gradient during diastole, you have mitral stenosis. Number two, a valve orifice area less than 1.5 centimeters square is the cutoff for severe mitral stenosis. You may also see the classic rheumatic changes on echo, like thickened mitral leaflets, commissural fusion, very high yield, and sometimes calcification. And here's something important to note. Unlike other volume overload lesions, there is no LV dilation. There is no LV hypertrophy in mitral stenosis because the problem is before the ventricle, not inside it, okay? Straightforward, right? Differential diagnosis of mitral stenosis. First, mitral regurgitation. This is the most common confusion maybe. Both involve the mitral valve and both can lead to left atrial enlargement and AFib. But in MR, the murmur is holosystolic, not diastolic. It lasts throughout systole and is best heard at the apex, radiating to the axilla. Also, over time, mitral regurgitation causes volume overload, leading to eccentric LV hypertrophy and laterally displaced PMI, both of which are not seen in mitral stenosis, where the LV is typically normal. So if you hear a systolic murmur plus displaced PMI, think MR, not MS. Left atrial myxoma. This one is important especially for step 1 vignette. A left atrial myxoma is a benign tumor that sits in the left atrium and can mimic mitral stenosis by intermittently obstructing the flow across mitral valve, But here's the clue. Symptoms tend to be position dependent. Position dependent. Patient may feel worse when lying flat or better when sitting up, depending on how the tumor moves. And of course, the echocardiogram will differentiate. It's going to show a mobile mass in the left atrium, often swinging into the mitral orifice during diastole. Pulmonary arterial hypertension can cause dyspnea, fatigue, signs of right-sided heart failure, just like mitral stenosis. But here's how you can tell them apart. In pulmonary arterial hypertension, there is no elevation in left atrial pressure, and the mitral valve is normal. Also, pulmonary arterial hypertension patients won't have a diastolic murmur, and the echo will show high pulmonary pressures without valve obstruction or abnormalities, okay? All right, management of mild to moderate mitral stenosis. These are the patients who are asymptomatic or have minimal symptoms, and the valve area is still, relatively preserved. The first step is surveillance. We're going to follow these patients with periodic echocardiography, usually every 1 to 2 years to monitor for progression. We're looking for changes in valve area, transmittal gradient, pulmonary pressures, and of course, development of symptoms. If the mitral stenosis is due to rheumatic heart disease, which is the most common cause worldwide, we give prophylactic antibiotics to prevent recurrent group A streptococcal infections. This usually means monthly intramuscular penicillin, and it helps prevent further valve damage, okay? And one important counseling point, if a patient has severe mitral stenosis, they should avoid pregnancy unless they've been evaluated and treated first. Why? Because pregnancy increases plasma volume, which can unmask worsened symptoms and lead to pulmonary edema or atrial fibrillation. Remember that management is not, the step 1 thing, but let's take advantage of our discussion and lectures to bring you concepts that will help you in step 2 and 3 as well. Management of severe symptomatic mitral stenosis. Severe symptomatic mitral stenosis. This is where you shift from monitoring to intervention. You're going to start with medical therapy, then we're going to move into procedures. And finally, we'll cover the indications for valve intervention, all very testable on step 2 and step 3. Okay? So medical therapy doesn't fix the stenosis, but it helps relieve symptoms or buy time until you get the intervention. First, we use diuretics like furosemide to release pulmonary congestion and volume overload. Beta blockers or non-dehydropyridine calcium channel blockers like verapamil or diltiazem help by slowing the heart rate, which improves diastolic filling time. That's important when the valve is so tight and filling is so limited. And if the patient develops atrial fibrillation, which is very common in patients with mitral stenosis, they will need for sure to be anticoagulated. And remember that for mitral stenosis, we're going to use warfarin. We can't use a DOAC. You can't use direct oral anticoagulants for patients with mitral stenosis. They are not approved in rheumatic patients with atrial fibrillation, okay? That's more for step 2 or step 3. If symptoms persist or the valve is clearly tight, we move to valve intervention. The preferred procedure is PBMC, percutaneous balloon mitral commissurotomy. Percutaneous balloon mitral commissurotomy, okay? That's when you use a balloon catheter to dilate the stenotic mitral valve. And it's ideal when the valve anatomy is favorable, non-calcified, pliable leaflets, no significant MR, these kind of things. So if the percutaneous balloon mitral commissurotomy is contraindicated due to, let's say, complex valve anatomy or coexisting mitral regurgitation, then we go to surgical valve repair or replacement, okay? So indications for valve intervention: 1, severe MS with symptoms; 2, severe MS with pulmonary hypertension; 3, severe MS in an asymptomatic woman planning pregnancy, okay? So these are all situations where early valve intervention improves outcomes even before EF or LV function declines, okay? Complications: if left untreated, mitral stenosis leads to progressive pulmonary hypertension and right-sided heart failure. As the left atrium enlarges, the risk of developing atrial fibrillation goes up, and once AFib sets in, the risk of thromboembolism and stroke increases significantly. Without intervention, severe mitral stenosis is uniformly fatal, okay? But here's the good news. With PBMC or surgical valve intervention, the prognosis is excellent, especially when done before the onset of right heart failure or before any stroke or complications like that. So timing is everything here. Okay, that's pretty much it for today, guys. Thank you very much for your time and attention. I hope you enjoyed the lecture and learned something valuable for your step 1. See you next time.